So this is the situation prevalent at HCG Asta Cancer Center, where I can hardly get in a word between Mansi first talking about pembrolizumab in triple negative breast cancer and then going on to talk about hormone receptor positive early breast cancer and then hormone receptor. She's going to follow me again to speak on hormone receptor advanced breast cancer, supported by the pharma between MSD, Eli Lilly and Novartis. And we are here with the HER2 positive early breast cancer, unsupported by any of you sitting in the last row. Anyway, but breast cancer, like Vani and Dr. Sagoo, I believe that it's an absolutely surgical disease, and we'll have a short run of a panel discussion on HER2 positive early breast cancer. So this is a lady, 3 years, enjoying marital bliss, 28 years old, left breast lump since about 4 months, no other symptoms, no medical morbidities. Obviously, we must have thought that it is something else because she was too young to develop a breast cancer at this age, but we all know that we often come across patients who are as young as this, premenopausal, obviously menarche at 12 and nulliparous. Unfortunately, she had a very strong family history. I will discuss this later. In paternal aunt, breast cancer, in paternal grandfather's sister, breast cancer in paternal grandfather's sister's daughter, prostate cancer in maternal granduncle. We have an excellent genetic counselor at HCG Asta Cancer Center, and this is her drawing the chart, and the round ones are the unaffected females and these square pegs are the unaffected males. So this is her diagram of a left breast lump, a 3 by 3 centimeter lump in the left breast at about 12 o'clock position. So my first question to maybe Pushpendra could be, what will be your next line of investigation for this patient?
Bilateral sonomammogram and then USG guided biopsy.
Okay, so this was the mammogram done at the HCG Asta Cancer Center, showing, as you correctly pointed out, that there is a hypodense lesion in the left breast, upper outer quadrant, and you can probably even see the lymph node in the armpits there. As you pointed out, a core riddle biopsy was done. It showed an infiltrating duct carcinoma, not as other specified, grade 3, ER positive, PR negative, and a HER2 3+, which is the topic of discussion today. An ultrasound of the axilla showed a 15 millimeter sized rounded node with hypoechoic center, partial loss of hilum at level 2, and an FNAC was done from that, and it turned out to be positive. We do not practice targeted axillary dissection as a standard practice, and therefore it was not clipped. Dr. Sagoo, what will be the metastatic workup that you would do for this particular patient?
This is an early breast cancer which is clinically T2N1 and probably we do a normal chest X-ray and ultrasound, but in my scenario where I work in a private setup, most of my patients, they ask for PET scan, and we usually recommend PET scan for node positive disease in a young patient.
So this patient, as Dr. Sagoo correctly pointed out, underwent a PET CT scan which showed no distant metastasis and a radiologically T2 3 centimeter lesion with nodes at the axilla. Dr. Naresh Jangid, would you consider neoadjuvant chemotherapy in this patient now that we have all the information? And what will be your cutoff, 1 centimeter, 2 centimeter, 3 centimeter?
Sir, more than 2 centimeter.
2 or more?
2 or more for neoadjuvant followed.
So that is the current practice, where for patients with tumors greater than or equal to 2 centimeters, either they are triple negative or HER2 positive, probably we would consider them for neoadjuvant treatment. Even if they are amenable to breast conservation surgery, any of the surgeons can take that question, Mihir. Would you consider surgery first or for a 2 centimeter appropriate tumor to breast ratio, would you still go ahead, and do you see any significant advantage of doing NACT first in a tumor which is 2 centimeter and an appropriate tumor to breast ratio?
Sir, I consider for NACT because the HER2 positive tumors are very high risk, and from NACT we get the high percentage of PCR rate, and PCR is very much high chances of long-term survival benefit. So I consider for NACT in these patients.
Dr. Vani, I knew that.
I will reword it. So essentially, there was a time when size was the only criteria that you would decide breast conservation versus not. And Amish will be very happy because I'm saying it. Systemic therapy has shown benefit in the high risk, high grade disease of triple negative and HER2 positives with neoadjuvant, because the response based adjuvant maintenance therapy has shown survival benefit. And if the patient is affording the next line, that means TDM1, then I would consider her definitely for a neoadjuvant here. Clip the primary because it's small and it will just disappear. You may not be able to identify the site. She would still be amenable for breast conservation. The PCR translating into an overall survival, hence we are giving, is really not the right answer, because that's not the reason why we are giving. It's also because residual disease being managed when they are not responding with the right kind of systemic therapy gives them better benefit. I think that is the main reason why we are agreeing with the medical oncologist to say, okay, we will go ahead because the patient benefit is definitely there.
So what I understand from what you are saying is that all node positive, irrespective of tumor size, would probably go for neoadjuvant chemo.
Yes.
However, size cannot be the only criterion for deciding for NACT, and you would individualize, and it's the individualization is more on because of the post NACT adjuvant treatment available to patients, which translates into better survival.
Right. Amish?
Yeah, so Vani would be happy the other way around at the end of the panel. If it is 3 centimeter T size and N0,
Yeah.
would all the panelists give NACT?
Can we have, starting from this side, yes, no?
Yes.
T3N0.
T3N0.
No, 3 cent, sorry.
T2N0, 3 centimeter.
3 centimeter. For example, this patient, but without the nodes.
If the nodes are negative.
Sir,
Not negative, there is option of TAP trial, upfront followed by TH.
APT between 2 to 3 centimeter, there were hardly 4% of patients. And APT worldwide is followed in less than 2 centimeter. I am coming to something else when again Vani would be happy, but I would like to know the panelist. Okay, let's cut the story.
Dr. Sagu, in your practice, 3 centimeter tumor,
Yeah.
HER2 positive, NACT surgery.
3 centimeter tumor with high risk features, young patient, high Ki67, LBI positive, PNI positive, definitely neoadjuvant chemotherapy, or an old lady with 3 centimeter tumor with low risk features, probably I'll go ahead with the upfront surgery with sentinel lymph node biopsy.
So every HER2 positive 3+ is considered high risk.
So what she's coming to is age.
No,
That we are
I
also
agree.
looking at other comorbidities and
My
age.
point is that I would have agreed till we had the affinity trial 11 year of data. In affinity trial, what the trial did was, if the node is negative in the pathological staging, you give only trastuzumab.
Yeah.
And node positive, trastuzumab plus pertuzumab. They had divided that. At the end of 11 years, 3 centimeter T2N0 with only trastuzumab, you have IDFS almost crossing at 87%. We do not have the data of dual anti-HER2, even 7 years of data. My point is, you are subjecting the patient to dual anti-HER2 in a 3 centimeter node 0. When you have 11 years follow-up data, go upfront surgery. If node negative, give only trastuzumab. If node positive, give dual. On the other side, ASCO 2025 said T1C may be dual anti-HER2 though. I think we don't have to blindly follow what they say. In India, with affinity, I feel it makes more sense that if the node negative 3 centimeter, I would now request Vani to operate rather than me giving dual anti-HER2.
Would that change your practice in a way where for 2-3 centimeter lesions, node negative, HER2 positive, you would consider only TCH as your part of new NACT because of this data that you have now? Use the mic. Can we have the mic? Vani is not going to keep it.
So for 3 centimeter tumors, node negative, so that was the argument that I was going to make, that you don't necessarily need to use pertuzumab. I think if you want to, like, keep your leg in both places, give neoadjuvant TCH. If there is a PCR, then continue with trastuzumab. If no PCR, you can give adjuvant TDM1. So I think that is also an option.
I agree, we were practicing like that only. What I am saying is, with the affinity 11 years of follow-up data, I am more confident that how much TDM1 is going to do. In a 3 centimeter node negative, we don't have that subset with TDM1. Catherine, although 7 years follow-up data is there available.
Correct.
But we don't have that subset. I am saying is, these are the subset where we blindly are following American guidelines and over-treating our patients. NSABP B27 was the first trial which showed PAT-CR improves the survival. But that's not the case. Again, we are mistaken there. Patients who are destined to do well, anyway will do well with adjuvant setting also, because the drugs are exactly the same. Similarly, TCHP versus post-op treatment with only trastuzumab, if it is showing up to 90% survival, why do we want to over-treat? This is the thought process.
Yeah.
And after the affinity 11 years, I have changed my thought process. Before that, I was practicing what everyone else was practicing.
So blindly we were doing TCHP for all patients. So there is, you need to risk stratify probably and choose correctly and wisely a subset of patients who might do well probably only with surgery or the addition of only trastuzumab is what you are trying to say.
So
Thank you, sir.
I guess the whole discussion is about being node positive or not. Whether
Node
it is
positive,
2
I think there is no
3
discussion on
centimeter,
that.
4 centimeter.
Node positive, no discussion.
Yeah.
Okay.
If it is node negative, then it is an individualization, and you also, even if it is 4 centimeters, if she is not affording TDM1, but she is amenable to upfront surgery, why would I look for the data and then decide? She is never going to take TDM1.
Okay. But would you have that discussion prior to initiating anti-HER2 therapy, that whether you will be able to afford TDM1 in the adjuvant setting or not? Absolutely. Okay.
Yeah, most
would
of
most medical oncologists do that?
Even
A raise of hands, Chintan, would you discuss that patients will be requiring TDM1 in the post-operative?
Yes, sir. So I draw a flow chart where I explain that this is the treatment, then there will be surgery, and there are options like if you receive PAT-CR or if you don't achieve a PAT-CR. If you don't achieve, then maybe you have to go for a TDM1, and this will be the cost, and this is the 14 cycles you need to take. So the total explanation is done on day 1.
But do you think with the availability of biosimilars also the acceptability and
So we give estimate for both the things, the innovator as well as the biosimilar.
anyone on the panel, I mean the questions are open now that it has become an open house discussion between Amish, Vani, Chintan, me and the panel. I think any of the panelists can answer that question.
even as a
Okay, so at least one thing that we agree is that patients who are HER2 positive early breast cancer tumor equal or greater than 2 centimeters, preferably node positive regardless of hormone receptor status, should receive neoadjuvant chemotherapy with the addition of trastuzumab and or pertuzumab. Again, this thing. To the medical oncologists in the panel, what will be your choice of, because money is not an issue? Pushpendra.
Sir, TCHP, which is
The first
option.
Oh, that is listed as first. So pertuzumab, trastuzumab, and an anthracycline-free chemotherapy. Any reason why you would omit anthracyclines in these patients?
Sir, we have a data from TRAIN-2 trial, which says that event-free survival is nearly same, hazard ratio was same. With addition of anthracycline, there is increase in the cardiotoxicity from around 4% to 7%, which was definitely
So I'm
higher.
aware of the
young
TRAIN-2
patient.
and the BCIRG 006 trial, but I also feel that patients who are HER2 positive, node positive, HER2 positive are candidates who are likely to benefit from anthracycline, because that is what we have been conventionally taught. So has that teaching been, now confined to evaluate only cardiotoxicity as one of the major factors, or would you still consider anthracyclines in some node positive, HER2 positive patients? Is there any,
Yeah.
flow chart for that?
In young patients, I still give anthracycline.
Thank
and
you.
second thing is NeoCarb trial in ASCO 2025, which we were always thinking what the hell carboplatin is doing in TCHP. Now they are answered in phase 3 that you can safely omit carboplatin and you can give THP. That was another way, like TCHP is no longer going to remain first this thing. The only advantage of TCHP was that during anthracycline, you can't give the dual anti-HER2 or anti-HER2. Many of us don't give. And that is a time if it is HER2 directed carcinogenesis, you are giving a break. That was the theoretical discussion. But in young patients, especially less than 40, I tend to give anthracycline.
Especially in patients who are not affording pertuzumab, would you consider so at least we have some consensus on that as well. TCHP, of course, is the standard of care. Eventually, we might move towards THP, and AC plus TH or AC plus THP are also valid options, irrespective of the cardiotoxicity and the other. This is from the NCCN version 2025, and they still list out all options because that is the way they work. So these are the timelines of advances in HER2, starting from 1998 when trastuzumab appeared to all the drugs that have been. So this was the NOAA study design, which showed that the addition of trastuzumab in patients with locally advanced or inflammatory HER2 positive breast cancer, neoadjuvant trastuzumab significantly increases PCR rates. Whether PCR rates significantly improves overall survival is trend towards event-free survival and overall survival benefit with the addition of trastuzumab to chemotherapy in HER2 positive breast cancer patients. Again, lot of data on the use of pertuzumab. Dual blockade is active in the neoadjuvant setting, yet chemotherapy still remains the cornerstone. So this is arm B, where pertuzumab and trastuzumab both were used in addition to the backbone of using chemotherapy, which showed a PAT-CR rates of about 45%, but now the rates are much higher. Dr. Mihir or Dr. Saggo or any of the surgeons, what is the average PCR rates in clinical practice in the breast, in the axilla, and TP, total PCR rates?
With the dual HER2 blockade, dual HER2 blockade, it is approximately 50 to 60% in the breast, and you can say that 40 to 50% in the axilla.
I somehow feel that the PCR rates in the axilla are higher than in the breast. They range up to 60 to 70% of in the your experience.
No, I think the primary does respond much better. There is a differential in the lymph nodes with less response in the lymph nodes. That is my observation. I don't know if anybody else has any other observation. That's my.
I think that is what Dr. Pushpendra was referring to, high PCR rates with or without anthracycline, which prompted us to drop one of the key players, anthracycline, which you have been, one of the first drugs used in the treatment of breast cancer. Because this study showed that no event-free survival or overall survival benefit from an anthracycline containing regimen in stage 2, stage 3, HER2 positive early breast cancer for N0, N1, N2, N3. Now, to complicate matters, this young lady, 28, because of that strong family history and as advised by our genetic counselor, also went on to have a genetic mutation, a BRCA positive. So, if this report have changed your choice of drug, would you have considered a carboplatin just because she is BRCA positive, or it doesn't matter, you know? Amish, do you think that if you had this information along the way sometime when a month after she tested for breast cancer, so
So this your patient of yours is ER positive, PR negative.
ER positive, PR negative.
That is what you have. In that BRCA1 right now information is not going to help me. If it would have been triple negative, then yes.
Any of the panel wants to make any comment at any point of time? Open house. So options discussed. Obviously, she was nulliparous. Fertility options were discussed for her, and a clipping was done. At the time of clipping, we didn't know that she was BRCA positive, but however, we went ahead and clipped her. So we have decided to give her 6 cycles of TCHP. Patient had an excellent response to the neoadjuvant chemo. Surgeons on the floor and in the panel, what are her surgical options? A right-sided breast conservation surgery, right-sided modified radical mastectomy, right-sided modified radical mastectomy with a left risk-reducing mastectomy, with or without reconstruction.
This patient will require detailed counseling regarding the options for the surgery and the options for, because she is unmarried, she is nulliparous, and right BCS is also a very good option for her with the close surveillance post the treatment. And she should also be offered and told about the oophorectomy after she completes her child bearing the family, and that's it.
Obviously, because she is nulliparous and she is very keen to get pregnant in the coming few years, after maybe 2 to 3 years of hormone therapy would be an appropriate time for her to consider undergoing fertility treatment. So probably breast conservation surgery would be the best, and now that she has had a good response to the neoadjuvant chemotherapy, probably breast conserving surgery is the appropriate treatment. Mihir and Dr. Vani, what will be your approach to the axilla? Remember that she was N1 prior to surgery. 2 or 3 nodes were positive. One of them was FNAC, turned out to be positive. Now there is the nodes have responded, but there is still evidence of a positive node in the axilla yet. ALND, SLNB.
I think that debate did the whole discussion already, that if it's a low burden disease, she was actually operable breast cancer to begin with. Yes, she was node positive, but then here she's had a lower level node only. You can see it is quite low lying, in fact, in the tail. So if she has either a low axillary sampling, which is proven to be better than a sentinel node biopsy in a post-chemo situation, I would be happy doing that. And if there are no nodes there, keep her under observation for the rest of the axilla. I will not radiate the axilla.
So for patients who are N0 prior to NACT, you can consider SLNB post NACT as well. N1 becomes N0, you might still consider doing a sentinel node or a low axillary sampling. However, if patients continue to have persistent disease in the axilla or were N2, N3 to start with, obviously you will go ahead with a complete axillary lymph node dissection, which remains the standard of care as you heard in the preceding debate.
Yeah, one additional point. See, age matters. One forgets in the whole story that younger age is a poor prognostic feature itself. And whatever you're seeing in somebody who's 23, 24 or 30 versus somebody who is 60, age really matters here, because younger age itself is a poor prognostic factor. So you have to keep that into consideration for individualizing planning. So it's not like you have an answer by saying that I'm going to do this and will do this for everybody.
Yeah.
The same thing as, where is it? One shoe fits all does not happen. Yeah.
Point well taken. As Dr. Sagu recommended, she went an ultrasound guided wire localization of the previously placed clip and a wired excision followed with an axillary lymph node dissection. I saw most of the medical oncologists overshoot their time. So, sir, breast cancer remains a surgically dominated, and I will refuse to step down till I have completed all my slides. So, this is a specimen mammogram. The clip was placed, the wire was placed, and she underwent a wide excision and ALND. She had a complete response in the armpit, but however, there was, I think, 8 millimeter disease in the breast, all margins and base uninvolved, no DCIS, no lymphovascular invasion. Quickly, adjuvant options for this patient, medical oncologists. Pushpendra.
Sir, to intensify therapy with adjuvant TDM followed by with radiotherapy to the breast because it was BCS.
Pushpendra in a previous avatar was a radiation oncologist. In this avatar, after doing his MD radiotherapy, has now done his DM medical oncology. So he wears two hats. So first he will give adjuvant. Oh, both can run concurrently actually. TDM1 and radiation. And hormone.
Hormone, ER positive.
Everything.
So in hormones, what are you going to do with the ovarian suppression? Are you going to plan HER2 positive
so as
disease?
ma'am said,
No.
ideally to be discussed and if possible risk reduction bilateral sarcopenic operation after completion of family, but before that AI plus lupride. Ovarian
Why
function.
AI? Why not tamoxifen and lupride?
Tamoxifen, to start with tamoxifen, after that to be discussed because young patient, high risk disease, residual after TCHP, so later on to switch with possible OFS plus AI.
Let me clarify to the organizers that I am no longer in control of this panel discussion and it is now a rolling open house. Anyway, so I would probably consider tamoxifen with some sort of ovarian suppression because she is a high risk patient to start with. And obviously TDM1 as recommended by the Catherine trial, which said that it decreased the risk of recurrence by 50% when compared with trastuzumab among patients who had residual disease after NSET with anti-HER2 therapy. Any experience, my favorite medical oncologist, Dr. Amish Vora, with the HER2 DX assay, where they have used it to predict pathological response, and do you think it will be of any value? Why would you want to do such an expensive test just to find out whether the tumor is ultimately going to respond or not? No. You would also consider lupride during the chemotherapy as well, I suppose, because to prevent. So these are all the studies that justify the use of. Would you add? No, one of the Mansi spoke about adding abemaciclib in this high risk patients who have residual disease after the initial treatment in hormone receptor positive breast cancer patients. Would you consider addition of abemaciclib in these patients at some point of time?
Sir, for germline BRCA, olaparib is preferred than the abema. It should be either sequential. We don't have an answer, but if I have to prefer, I will prefer olaparib.
I think that question has already been answered by Mansi, where she said if you have a targeted treatment in the form of olaparib because she is BRCA mutation, you would probably consider olaparib based on the Olympia trial rather than going ahead with abemaciclib. I think for this thing of time, we'll skip the further trial, but based on this text and the soft trials, you would probably consider tamoxifen and an additional ovarian function suppression. To the radiotherapist, Dr. Rajal, what would be your field of radiation for this patient? Remember that she has a breast conservation surgery with node positive,
As the radiation therapy is decided by the clinical status before at the type of presentation. So here BCS is done, so whole breast will be considered as a target, and I will prefer supraclavicular also to treat because node was positive, and to prevent morbidity I will leave axilla. So I will consider.
You will spare the axilla?
Yes.
Chest wall and regional nodal radiation
SCF, yes.
with a boost to the cavity.
Yes, sir.
Again, these are the guidelines on which we would do a hereditary genetic panel testing. Usually it's a comprehensive genetic panel testing rather than checking only for BRCA1, BRCA2, which was a point of discussion in some other previous this thing. I think with that we come to the end of today's discussion on HER2 positive early breast cancer. This is the team at HCG Asta Cancer Center, and this is the new center. I invite you all over the weekend to come and visit us. Thank you.
So one point about ovarian suppression, EBC TCG meta-analysis which was published in 2023, the criteria was less than 55 years, but the absolute benefit, if you see, because they give the reverse graph, absolute benefit was in patients less than 30 years of age. So I think we have to try our level best in this group, even though infertility or whatever aside, it reduces the recurrence rate by 10%. 39% to 29%. This is not a small amount. I think these are the patients where by hook and crook somehow we have to give them ovarian suppression, of course with counseling with the patient.
Thank you, sir.
So one last bit I'll add. The story never ends here because she's young, she's unmarried. You're going to put her on hormone therapy, ovarian suppression. She will get married, she will have to have a child. So the story actually goes on, not for this panel, but eventually how to plan, so the positive trial, the results, when to discontinue tamoxifen or ovarian suppression, when to let her conceive and when to come back, and how will that affect the outcome. So I think it's an ongoing discussion and counseling that the patient needs, and it will never end with just this.
Thank you, Amish. Thank you, Vani. Thank all the panel members. Thank you, the organizing committee of the Shelby Cancer Center.